The following podcast is part of a certified educational activity titled Winning Strategies for Diagnosing and Managing Chronic Obstructive Pulmonary Disease, featuring Dr. Fernando Martinez from New York Presbyterian Hospital, Weill Cornell Medical Center in New York, New York, and Dr. Melan K. Hahn from the University of Michigan in Ann Arbor, Michigan. Access the entire activity and complete the post test at peerview.com/YAX860. Downloadable slides and practice aids are also available.
My first section here, we're going to talk about screening for COPD. Dr. Martinez is going to talk a little bit about management, and then we're going to wrap up with some kind of practical advice about adherence and inhaler strategies to optimize care for patients. So I'm guessing most of the people in the room this morning are either pulmonologists or work closely with pulmonologists. So I know I'm preaching to the choir a bit, but we do have a major problem with COPD underdiagnosis in this country. And I think it's really several-fold with respect to both patient lack of recognition and primary care physician, in some cases, lack of time. But things that we need to be thinking about are symptoms, risk factors, and then ultimately getting spirometry. I think, as many of you know, roughly only about a third of this patients in the country that have a diagnosis of COPD have actually had confirmatory spirometry. I actually run a transitions of care clinic to see patients after they've gotten out of the hospital. We all know this is very important because of CMS looking at the readmissions issue quite closely. And what's shocking to me is that roughly 15% of patients who were discharged for a COPD exacerbation didn't even actually have COPD when we got them into clinic and tested them. So a lot of times I know our colleagues have to make, or if you're in the hospital, have to make decisions on the fly. But I think for me, it really does underscore the problem that we have with even just getting the diagnosis right and obviously staging. So when I think about COPD and what we can do to ultimately, let's say, eradicate the disease, we've got to prevent, we've got to detect early, and then we need disease-modifying therapies for patients that have established disease. So I'm going to focus a bit on early detection this morning, but I think that where the research has had it is kind of younger and younger, trying to help us understand what's going on in 20 to 30-year-olds. There's a couple of cohort studies that are starting now, and even into childhood, what are the things like respiratory infections in childhood that could ultimately contribute to COPD developing as an adult. So as I mentioned, there are a lot of undiagnosed patients that need to be treated, and so I'm going to be spending a few minutes talking about that. What I'm not going to have time to talk about today, but would be an entirely separate talk, are the people that don't fit our current definitions for COPD, but potentially should be treated. So we've got increasing data on the fact that patients who do not meet our current criteria with respect to airflow obstruction still having symptoms, exacerbations, increased mortality. And this was, Fernando and I just got back from the European Respiratory Society meeting where Gold met. And this took up like half a day's worth of conversation, is what to do about all this information coming in, and do we need to actually redefine the disease. I don't expect there to be any major changes the next year, but it's definitely something that we're thinking about. So I mentioned I've been thinking a lot about why we have so many people that are undiagnosed. I'm actually running an early COPD study right now. And so we're running all sorts of social media advertisements, and we're bringing people in who smoke and doing spirometry and trying to get them enrolled in this study. And to me, it's been absolutely fascinating, the disconnect between the spirometry and what patients have been told in primary care clinic. I had one gentleman just last week, he was told, oh, your early COPD, first spirometry ever, and his FEV1 is 35% predicted. And they still hadn't done the spirometry in the office. This is the kind of thing that we're seeing. So what are the issues? How can we fix this? Well, we know providers are limited on time. Some of them may not either understand spirometry, think it's not covered, aren't comfortable with ordering it. And then a lot of times, they're busy and may not ask about activity limitations and things like that, particularly if patients don't bring it to the forefront or have other things to discuss during the day. From a patient perspective, I think we need to do as a community a lot better job of educating our patients about the symptoms, things that are not normal, not just parts of normal aging, and help empower patients themselves to recognize the symptoms and actually ask their physicians about getting spirometry. Now, this came out in JAMA in 2016, and technically and factually, I won't argue with it, but unfortunately, the U.S. Preventive Services Task Force continued recommendation against population-based screening in asymptomatic individuals does not really help the cause here. And I think a lot of people who maybe don't read the document take away the message, oh, we shouldn't even bother. And so I think it's important to delve down into that document a little bit more and think about what they're really saying and what evidence that's based on. So it's really worth noting that they mention asymptomatic individuals or not. There's no evidence for screening asymptomatic individuals. But I think as we know, patients, if you ask them, may say, are you short of breath? And they'll say, well, no. But they maybe walked the golf course last year and this year they're taking a cart. So they're self-limiting their activities to avoid dyspnea. So that may not always be the best question. The other important thing to remember is that the recommendation is actually based on lack of evidence, not negative evidence. Fernando and I are actually involved in a study to try to validate a screening tool in a large primary care based group. So, these studies are hard to do, but hopefully the evidence basis is coming. We really do need these kinds of studies to hopefully overturn the U.S. Preventive Services Task Force recommendation. So what many of us are focusing on is not screening necessarily, but what we call case finding. So enriching the patient population for people likely to have COPD. And this is really the approach that GOLD recommends. So how big is the problem? We know, the estimates vary on how many patients have COPD, but this data now, I guess it's funny, I've been showing the slides for a long time now and just making me realize how old I am. But anyway, this is data that Dave Menino published when he was with the CDC. And it shows that the patients who actually had a diagnosis of COPD in blue, there was a significant disconnect between those and those who actually had airflow limitation when you tested them, which is the orange bars. So significant increase, particularly in spirometrically defined COPD as patients get older, with nearly a quarter, at least in this study, of patients over 75 actually having airflow obstruction. So one could argue, well, does it really matter? Do patients who are not diagnosed, it's probably because, you may be thinking, well, it's probably because they're not actually having any problems. That's why they haven't actually come to anyone's attention. And that actually simply isn't the case. So this is actually data from CanCold, which was a large population-based study in Canada designed to look at airflow obstruction. And what they demonstrated was that there actually were a significant number of respiratory events, exacerbation-like events, even among patients who did not carry a diagnosis of COPD. Now, it was a little bit less than the diagnosed, but clearly still not zero. And so I think this helps us to understand that these patients who are flying under the radar are sick. Now, this is actually some data that my former mentee, Carlos Martinez,
No relation.
not to be confused with this Martinez, actually worked on along with David Menino. And what they demonstrated was that even undiagnosed obstructive lung disease is still associated with a pretty significant decrease in survival over time, and actually is pretty close to patients with diagnosed airflow obstruction. So I think, again, this just really underscores the problem that we've got really on a population level, and some of the things that we're going to be struggling with when we see these patients come in that really haven't been adequately evaluated on the outpatient side. It is, I think it's well known that sometimes patients present with, for the first time with a hospitalized exacerbation for COPD. So, as I mentioned, Dr. Martinez and I are working on what we can do to improve case finding for COPD. Now, you may be aware there are a lot of screening tools that have been looked at. COPD screener is, I think, a popular one. All of the existing screeners, except for Capture, are really based on sort of expert opinion, maybe going through the literature and trying to figure out which questions from an epidemiologic standpoint were most predictive. And those are all good approaches. But what we did for capture was a bit different. We did those things. We held focus groups and things like that. But we kind of used multiple methods to gather a large item set of what we felt would be the best questions, and then used sort of machine learning approaches to derive the absolute best set of questions. So we ended up with a subset of 5 questions. Things like, have you been exposed to dirty air? Does your breathing change with the seasons? Do you have activity limitation? Do you tire easily? And essentially trying to get at, have you had a respiratory event or exacerbation? We then combine those with results from peak flow to develop kind of a risk score with a suggested recommendation for whether the patient should go on for screening with spirometry. And I'm just curious, I've just shown you those 5 questions. Does anybody notice what's kind of missing from this list that perhaps is on most lists? Right? We don't have a single question on here about do you smoke? So intriguingly, we actually did look at that question, but one thing, it actually didn't perform any better in the test set. And I actually think this makes this questionnaire incredibly unique, because we all know that non-smokers make up almost a quarter of the patients with COPD, right? So I think this is our first attempt to really try to capture these patients through a more formal screening questionnaire. So this is what it stands for: COPD assessment in primary care to identify and diagnose respiratory disease and exacerbation risk. One of the interesting things is that when we developed these test items, we weren't just trying to find COPD, we're trying to find clinically significant COPD. So patients with either high symptoms or likely to exacerbate that really would warrant therapy.
All right, so what Melan was talking about is really a very hot area right now, this idea of identifying individuals that are undiagnosed. This capture program that we're involved in is a study at 100 primary care centers across the U.S. The goal is to be able to have those individuals in primary care identify these patients and work with you and manage them. So, keep track of what occurs with that, because that's aimed at improving identifying these individuals. I'm going to talk about COPD assessment and management, really following what the Gold Science Committee that Melan and I are both involved in are now advocating. So to remind you, the current assessment is based on spirometric diagnosis. Spirometry is not out, it's just used for diagnosis. And then therapeutic assessments are based on the construct on the right. And so that is the concept that you are evaluating a patient's symptoms and a patient's risk of exacerbation, principally by prior history of exacerbations. So high symptoms, B or D, low symptoms, AC, high risk for exacerbations, CD, low risk, AB. So that's how that whole schema came about. The idea that you're going to ask and you're going to continually assess these 2 constructs. So the goals of management, I think, remain the same. These are things that we've all accepted. We're going to improve symptoms, minimize exacerbations, improve health status. That's a given. The question is how we achieve that. So in that gold strategy recommendation, that A, B, C, D is based, at least with this slide, on initial treatment. That's why it says initial on top there, with a series of therapeutic options based on where the patients are. It's not one therapeutic option in most of these, because there are potential options that you can choose from for individual patients. And I think Melan and I have spent a lot of time trying to figure out how to characterize individual patients to give you further guidance on how you could make decisions between those recommended options. And we're going to give you some of that information. For example, in a very recent systematic review, one of these Cochrane reviews, comparing dual bronchodilation with other comparisons, one of the things that becomes evident is that dual bronchodilation is better than single bronchodilation. Dual is better than single. So in general, whether it's lung function, this is an exacerbation reduction potential, dual is better than single. This point down here, dual bronchodilation versus a LABA ICS, is a very controversial topic that I will address in a follow-up question. So in general, dual tends to be better than single. Okay? All right. So then one of the areas that I think is particularly interesting is this area of when you would consider dual bronchodilation versus an ICS LABA. And this to me is where you start seeing where some of the gold schema is actually helpful. So this is actually a sub-analysis of a study that Melan and I were involved in, which is the IMPACT study. severe COPD, actually very high risk of exacerbations, comparing triple versus each of the duals, dual bronchodilation, ICS-LABA. This is the comparison of dual bronchodilators versus ICS-LABA. So there on top you'll see dual bronchodilator, ICS-LABA. And what's interesting is if you have people that have less frequent exacerbations, so the A, B category in gold, the LABA-LAMA actually does okay in that setting. If you have people that have 2 or more moderate or a hospitalization, the CD, there's where you see the steroid regimen winning. So this data set to me is particularly relevant because it gives you a granular sense of an individual patient's where you're likely going to be seeing your decision-making go. There's another piece of information that came out of this study, and that was in patients that came into the study that were only on a LAMA. So if you, as the clinician, only had that patient on a LAMA, the LABA-LAMA actually almost won in that comparison. So again, less severe patients, the LABA-LAMA is not a bad option. More severe patients with exacerbation risk, that's where inhaled steroids generally have an effect in that population. One of the big problems for us, not problems, challenges for all of us, is triples, because you now have one available triple, and you have several more that are in the pipeline. So that is a device that has a steroid, a LABA, and a LAMA all in the same device. And there have been a whole series of studies, and in general, when you compare triple versus the dual bronchodilator, you compare triple versus the ICS-LABA, the triple generally wins in that setting. So part of the question for us is, at what point do you consider triple to be the principal therapy that you're going to use? And so that's where some of the data are evolving that give us some pieces of information. The other piece of information that came out of the IMPACT study, which is particularly impactful, no pun intended, was that in this study, this is now the probability of dying in the trial by both steroid-containing regimens and the dual bronchodilator. I mean, you know, that is not a subtle difference in terms of all-cause mortality while you were on treatment. Remember, this is a very sick population of individuals with COPD. So in my mind, I've taken this information, so the sicker the patient, the more likely I'm going to consider a steroid-based regimen. And in that case, I think that's a useful piece of information. There's a separate continual analysis of the data set with much more complete follow-up. I think it's missing 0.4% of the entire population of 10,000 subjects. And this is an abstract that was presented at the ATS a few months ago. And in that setting, whether it's all-cause treatment, whether it's off-treatment data, on-off-treatment data with all the components, all the data included, you know what? You still see a 20 to 30% reduction in mortality in this population. So this, in my mind, has been an additional piece of information that allows me to consider how I'm going to use the therapeutic options that I have available. There is risk to steroid-containing regimens. There's benefit. I just showed you the benefits. There's risk, and that risk includes pneumonia risk. And that's the EMA reviewed this a couple of years ago. This is 2016, and they concluded, yep, you know, COPD patients on steroids have a risk of pneumonia, although they still outweigh the risk. But given the shift towards personalized therapy, the question has come, how do you tell an individual patient sitting in front of you in a clinic setting? And for that, there are data such as these that we generated from the fluticasone vilanterol program, the ICS-LABA program. And for individual patients, pneumonia risk was principally seen in patients who were older, generally male, people that had a previous pneumonia, that were skinny, and had more severe airflow obstruction. And so when I start now seeing patients in clinic and I'm trying to decide what I'm going to consider, if it's an old guy who's really skinny, who's had a prior pneumonia, that is a person, that individual has a higher risk, and you're going to consider in that component the risk as well as the potential benefit. Now, the interesting component in IMPACT was that if you looked at the overall burden, so this is exacerbations, this is the LABA-LAMA, and this is the ICS-containing regimens, there is clearly a decrement in exacerbation rate with steroids, and the reverse is seen here. There's a slight increase in pneumonia. But this gives you a sense of the magnitude of the difference versus exacerbation reduction versus pneumonia risk. So what we're trying to provide you are data that allow you to make individual decisions so that you can decide an individual patient. Where is the greatest benefit? Where is the greatest risk? And you balance that for an individual patient. That's where I think some of the IMPACT data are most helpful, because it really gives a lot of clarity. You also have to realize that another steroid-related effect, which is bone abnormalities, generally tends to relate to the dose and the duration. So that as you reevaluate patients over time, this component of how long to keep a patient on an inhaled steroid is another component that we want you to understand. And so that's why there's a whole component in GOLD that is the sequential evaluation so that you can make decisions regarding follow-up treatment recommendations. So that's where these schema came. For dyspnea, that's the x-axis of that quadrant, and for exacerbation reduction, which is the y quadrant of that, the y-axis of that quadrant. All right, so keep that in mind, because we're going to focus right now on exacerbation management. And so again, you saw initial therapy in that quadrant earlier. This is now a question of what you do over time in individual patients as you reevaluate them. And there are these little tiny asterisks that are present in the figure, and that relates to the evolving data regarding eosinophils. In this particular steroid budesonide, and this is the impact fluticasone data, that's remarkably consistent. There is a relationship whereby the greater eosinophil count, the more you see separation with improvement in steroids. And the threshold seems to be at about 100. Less than 100, you don't see a lot of steroid benefit. At about 300, you see more steroid benefit. And so those thresholds have been incorporated in this schema. So if it's greater than 300, ICS-containing regimen. So that's where those data are coming. But you'll see it says consider if EOS. It doesn't say you must use an EO to make that decision. And that's in part because there are a lot of nuances to EOs that are still evolving. But the data are really pretty solid. All right? Now, in patients who continue to have events despite being maximally treated, there are two approaches that are considered. So roflumilast and azithromycin. Roflumilast is a drug that really is sort of the epitome of personalization of therapy, because we now know that drug has an effect, but it has an effect in a very narrow population of patients. That is, patients that have chronic bronchitis by the classic criteria and have had at least one hospitalization in the last year. So it is a very narrow group of people where you see benefit with that drug. So that's where that drug is positioned in that GOLD schema towards the bottom. Chronic bronchitis, prior respiratory hospitalization is the patient population. Azithromycin, from a study that Meilana and I were involved in that you guys funded in the US, this is an NIH study, azithromycin clearly had an effect that was beneficial compared to placebo on exacerbation rates. This drug has its disadvantages, antimicrobial resistance, some hearing abnormalities, QT, you got to be careful with it, but it clearly has an effect even on top of triple therapy. That's in part why it's positioned in that role in the GOLD schema. Remember that one of the key components of GOLD right now is this reevaluation. Risk, benefit, initial therapy, escalation, de-escalation. And so there is a positioning of de-escalation of steroid therapy in the appropriate patient based on two large studies. The Wisdom study that withdrew steroid to dual bronchodilator, no effects over a year on exacerbation rates, that's both of those. The Sunset trial was a 6-month study in a lower risk population from triple to a dual bronchodilator, no difference in exacerbation rate. And that is why in the GOLD schema there is this recommendation that you consider stepping down in the appropriate patient. And furthermore, in both of those studies, the eosinophil level was highly predictive of a patient that would do well with steroid taper versus not. And look at this. The threshold is around 300 to 400, 300. So in patients who are on longer term steroids, who've been relatively stable, and you're thinking, do I want to keep this for the next 5 years in this person? Duration and dose are related to some of the adverse events. I think eosinophils in that setting do have the advantage of giving you a little bit more granular guidance regarding when it's safer to taper that steroid versus not. Okay? Does that make sense? So now the last component, which I think Meilana is going to tackle principally, is something that is equally as important. It's how the patient uses their device to make sure there's maximal benefit.
So the last section here, we're talking about inhaler technique and adherence. And I really view this as part of the management review cycle that Fernando just talked about. That's something new that GOLD added. I think it makes sense. It's something that we all do, but they kind of gave us a little bit more granularity on what kind of things should be included at that review visit. And certainly inhaler technique and adherence, I think, are key parts of that. So it's actually really interesting when you look at adherence across all chronic diseases, that includes diabetes, heart disease, et cetera. Adherence for respiratory medications, in particular for asthma and COPD, tends to be the worst across the board. I have to admit, I don't fully understand that, but more than half of patients with COPD will stop new prescriptions after the first month. So that actually means for the majority of your patients, when you send them out with that new prescription, they probably won't be taking it on odds. They won't be taking it the next time that you see them. And sustained adherence continues today over time. Now, this really matters because it's associated with poor outcomes for our patients, whether that's poor symptom control, worse quality of life, increased mortality, higher healthcare expenditures. You can see here just some secondary data analysis from the TORCH study showed that for patients who were more adherent, they were much less likely to be dead at 3 years. So, what do we do about it? Honestly, I think one of the first things we have to do is explain to our patients why we want them on the medications. I think because of some of the short-acting bronchodilators like albuterol, et cetera, patients are very much used to kind of getting that quick hit for medications, and if they don't get that immediate, oh, I feel much better, they may not realize that it's important to take it anyway, that there are added benefits beyond their immediate symptom relief. So I think part of it is helping patients understand that there's some preventative and maintenance aspect to their medications. We want to try to simplify the treatment regimens as much as possible. So that also talking to our patients about what's working for you, what's not working for you, or, if it's a twice daily, would we be better off with a once daily, or is there a problem with the formulation? There certainly are other things that we can do to try to intensify the treatment regimen. One thing is to fill out and make and create an individualized action plan with our patients. I think it's really important that we inspire our patients to be advocates for their own health and to be partners with us in their journey with COPD. So I think filling out an individualized action plan together, there's actually free ones available, for instance, from the COPD Foundation, is a good way to engage patients in partnering with you for their care. There are other things like home visits, but there's even, I think everyone's aware, there's monitoring devices, for instance, that can be used. Some of the electronic medical records now directly link with pharmacies, and you can actually look at fills, which can also help. So there's a lot of things that we can do, but I think it's really important to help patients understand why it's important that they take their medications and give them a certain sense of ownership and responsibility and management over their own disease to partner with you. So adherence is one issue we struggle with. The other issue is that if a patient is failing a regimen, and we're again going through that management review cycle, we need to think about, is it actually the drug's not working, or is it they actually just aren't getting the drug to begin with? And so it doesn't actually even matter what device type a patient is using. There is always room for error. There's always some way that it can get screwed up. So with the metered dose inhalers, they may be inhaling too quickly. For the dry powder, they might be inhaling too slowly. For each of them, there may be issues with the actuation, the coordination, the timing, et cetera. So the data here just suggests that unfortunately errors are high. And GOLD now actually recommends rechecking inhaler technique at every visit. I will be very honest with you. Sometimes that's hard to find the time. Sometimes I'll do it myself. Sometimes I will bring one of my nurses in at the end of the visit. I definitely try to do it at least once if there's been an inhaler switch. I think all too often, what happens is I write one prescription, the patient leaves the office, they get a call 2 weeks later that the pharmacy won't fill it because there's some formulary issue. The patient gets put on a completely separate drug. They come back and, I trained them on drug A, but now they're on drug B. So unfortunately, this is becoming an all too common occurrence, but does really emphasize the importance of at least thinking about that, not just at the first visit with a patient, but at subsequent visits. So there actually is an association, believe it or not, between critical inhaler errors and outcomes. So whether we look at hospital admissions, ED visits, or just needing to be treated with antibiotics or steroids for an exacerbation, there is a roughly 1.5-fold increase in any of these undesirable events when patients aren't taking their medications correctly. So that's obviously incredibly important. So when we're thinking about which inhaler to choose for a patient, there's obviously a lot of things that are going into that decision. I always have discussions with patients about once a day, twice a day. Well, this particular class comes in, sort of these kinds of formulations. What do you think has worked for you? Are there kinds of medications that in the past you just didn't tolerate or couldn't coordinate for some reason? Um, there are things that it's becoming more and more common now to check peak expiratory flow rate. I will say that we do this. I don't do it at every visit, but this is something that we do for select patients in my clinic. And one thing that's interesting is that uh, often, most of the time, I would say, when you test a patient on it, they're not inhaling correctly for the device that they've been chosen for or selected for. But many times that patients can be coached into using into getting that right. Although, of course, there's the secondary issue of, well, I coached them right now, but is that going to be sustained over time? So it's always definitely something to think about. And I think in an ideal setting, again, we'd be rechecking patients at every visit. Now, ultimately, sort of the big, 1,000-pound gorilla in the back of the room is that sometimes for cost or insurance reasons, the choice is sometimes taken out of our hands. And so I don't know about your practice, but usually if it's, I'll go ahead and let the patient try whatever it's been selected, but then if it's clear that there's failing, then we'll go through the trouble of pushing back on the insurance companies to get patients on what I think they would actually do better on. So again, some of the other patient-related factors that we need to consider when we're trying to just select a device include things like cognitive impairment, as well as physical impairments, such as things like arthritis or inability to coordinate. There are a couple of things that can help. There are certain validated teach-back methods for specific devices. I'm sure, like your clinics, I have a huge bucket of devices for patients. Now, ideally, they would be practicing on their own inhaler. So one thing that is nice is to try to remind your patients to actually bring in their own inhalers to every visit. I know that can be a little bit of a bag of stuff, but it's really best if they're actually, putting their mouth on it, using their own devices to make sure that they're using them correctly. And then, as I mentioned, there are things like the in-check dial that we can use to assess and train patients on as well. So, in order to just therapy appropriately, again, I've been harping on this for the last 5 minutes, it's really important to just, again, reassess patients at every visit. And you've got to kind of think about it separately. Is it the drug? Is it the device? Or is it their technique if there is an issue? And that's really your opportunity to reassess. So we've talked about a lot this morning. We've talked about screening for COPD and some of the newer approaches. We're hoping, when is CAPTURE supposed to read out? We're hoping that we will have data from the CAPTURE study in the next few years. We actually are working on a couple of abstracts, though, that'll be presented at ATS. We've talked about the new kind of gold strategy to focus on either on symptoms and exacerbations and follow up with respect to treatment choices. That LAMA is great in patients, particularly who are highly symptomatic, but that ICS may make a lot of sense if patients are having frequent exacerbations, particularly with high eosinophil count. And then this concept of the management review cycle, reassessing adherence and inhaler technique and efficacy of particular medications at every visit.
So for those that you can't control at the change at the pharmacy, but there's an unaffiliated website called useinhalers.com, and it will actually give your patients feedback on how they're using their inhalers. It has almost every brand, and it'll walk them through. So maybe worth mentioning that resource to a patient before they even get to the pharmacy. So should it be changed after your training, they have some resource for relearning a new inhaler to at least start that journey.
Say it again. What is it?
It's use-inhalers.com. There's a free and a paid version of it, and it has almost everything, but it's a really great resource.
Yeah, I should also mention the COPD Foundation also has a free app that has the videos, and sometimes I'll actually run those, let the patient look at that while I'm trying to click all of the EMR things. Pharmacists are actually another untapped resource for this sort of thing. So you can tell your patients ahead of time, if for some reason you get to the pharmacy and it's different than what we discussed, you can ask the pharmacist to walk that inhaler through with patients as well.
So, Melan, given that this was one of the questions, and we still haven't answered it, what is our stance on peak inspiratory flow rate measurement? I'll let you tackle such a simple question.
I think how a patient uses an inhaler matters. I think the number of patients for whom they physically can't generate the correct peak inspiratory flow is probably low. But I do think the patients that are kind of inhaling at the wrong rate for the device, whether that's high or low, is high. So I think it's a little bit less of an issue of can the patient generate the adequate flow, and a little bit more of an issue of are they actually doing it right for the device they've got? And so I think it actually can be used somewhat as a training tool, actually, to help patients understand this is how you breathe for this device.
Yeah, there are a lot of data that are being generated now to try to address the frequency of peak inspiratory flow rate measurements, how it should be used. I'm like Milan. I mean, I think this is probably how I use it now as well. I'm not exactly sure how that's going to pan out long term. So Milan, there's a second question that I think is quite relevant because you've done this work when you did that massive project with Lancet Respiratory Medicine. How do you manage denial in patients that are diagnosed with COPD?
It's really challenging. I actually was at a forum with COPD patients yesterday, and actually one of them was saying he was doing a lot of advocacy work for various foundations and things like that, and was still actively smoking, and kind of had to come to grips with that for himself. It's really hard. I think for the good news is for many of our patients, they're going to be our patients for a long time, hopefully. With adequate treatment. And so I think developing a good relationship with patients and over time, trying to, kind of help them understand this is hopefully in most cases not a death sentence, but rather a chronic disease that we want to partner with them through and to better manage their health. Sometimes engaging caregivers and family members, I think, can help too.
Yep, I agree. That's actually in part when we generated that capture instrument for primary care. That first item that was not an accusatory smoking item was in part meant to minimize some of this potential denial issue. Let me address a couple of these questions that we got, Milan, since I've given you all of these things. So we were both involved in the azithromycin study, which was a one-year study. And so the question is very practical, and that is, are there any good data for going longer than a year? Not that I know of. And so that study was a one-year study because it was the practicalities of your budgeting through the NIH for that trial. It was a one-year trial. And so it is not unreasonable to consider the potential of de-escalation at some point, as you would consider with an inhaled corticosteroid. I mean, I hate to have people on medications for life when there are potential risks to those, but there are absolutely no good data on how to address de-escalation from azithromycin. I wish I could tell you. A really good question. I don't know any data regarding that. So the next question, which is a gold question, which is, should mucolytics be on the gold recommendations? Mucolytics are actually mentioned in the gold statement. The challenge with mucolytics is that the most positive mucolytic data come from large studies in areas where there was generally under treatment with inhaled medications. And so the quandary has been that there is an effect of mucolytics in people who are not on inhaled steroids, not on dual bronchodilators. That's not the population that most of us see, certainly in this country or in Europe. And so mucolytics are mentioned, but they're mentioned with a caveat. They're not in any of the algorithms because the data sets in comparison or in addition to the inhaled therapies just don't exist robustly. That make sense?
Yeah.
You want to grab one of your questions?
Sure. Well, I have kind of a fun general question here. Why is it so difficult to treat COPD? One of my favorite quotes, I think, is from Bart Shelley, who said, think about it. We take a disease that's defined by fixed airflow obstruction, and then we throw bronchodilators at it. So it is one of the inherent problems. I think the thing that I struggle with the most is just the heterogeneity of the disease. So it's Steve Renard a couple years ago wrote an article, and it's called COPD, an Orphan Disease. And in many ways, I think it is many little orphan diseases that we are trying to treat, and each patient's somewhat trial and error, and it does take me some time to figure out what works. In some cases, I really struggle to find an approach that keeps exacerbations at bay. I think the good news is that we're doing more and more research to help us individualize treatment plans, even things like eosinophils that I was extremely skeptical about and still have a little bit of skepticism about, but the data I think is increasing. That's one of hopefully many other tools that we'll have to subtype patients. I don't
Yep.
know, Fernando, you have
No,
thoughts
no,
on why
I
COPD is so
agree
hard?
completely with that. And, so I trained under Barcelli, so I have the same positive philosophy that Celli had. And there's a lot, there have been a lot of advances that have occurred in COPD just in the time that I've been working in the COPD arena. I mean, really, there's a lot of major advances that have been made in therapeutic approaches. We're now making enhancements in diagnostic approaches. Hopefully the capture program that you're working on, Milan, will allow us to have early diagnosis in a legitimate fashion. But there's a tremendous amount of work looking at potential mechanisms and how to target specific mechanisms in COPD patients, how to really refine this precision therapy. So Milan, you're involved in several of these biologic studies that are ongoing now. So don't give up on the COPD world, guys. I mean, it's a very common and a very prevalent problem. You've made a lot of advances already, you guys, and now you're refining some of those advances. So I'm a fully confident person. So my last two questions are not easy questions. You guys asked really good questions. I wish I could tell you I had a dramatic answer for each one of these. We've been tap dancing around here on some of these. So a patient that has severe asthma and an FE1 FVC that's less than 70%, why is that person not called COPD?
There's no agreed upon definition for asthma COPD overlap, and further, Gene and Gold just decided to divorce on the ACO document. So I think probably what we're beginning to recognize is, I mean, we ultimately want to target mechanism, right? So I think what we really need to do is to understand what the pathophysiology is of a patient, who has potentially airflow obstruction that was originally driven by, say, air pollutants and the type of inflammation, regardless of perhaps the level of airflow obstruction, versus a patient that perhaps has allergic inflammation
Right.
but has similar pulmonary function tests. So, I think what we call it may end up being less important, but really trying to understand the pathophysiology behind it so we can choose appropriate therapies.
Yeah, I mean, I think that's absolutely correct. For some of you that are older, as I am, not these young people, you will remember that there was a Venn diagram in the original ATS statement that had asthma, COPD, chronic bronchitis, and then it had the box for airflow obstruction. We're sort of coming back to something like that and
Still
realizing that mechanistically there are overlaps between these components. This whole ACO thing has been such a flog, such a battle. The last question that I'll address is, I'll pose one to you, Milan, because I know you've worked in this area, and then I'll tackle the last. It's a two-parter. One of them is, how do you address cachexia in a COPD patient?
Unfortunately, I don't think we have a lot of good data. We know it's associated with poor outcomes. Unfortunately, I think every intervention nutrition study for COPD that I'm aware of has actually ended up being negative.
Yeah.
But I do my best. We do have a nutritionist that I can have patients talk to. Sometimes they can get a little bit of support through pulmonary rehabilitation. We do try to build up their muscle as best we can through that, and then advise them on caloric intake. It's something that I track at every visit, particularly for some of my more severe patients. But I wish I had a magic bullet for that, and I don't.
Yeah. But so it is important. So this person is absolutely correct, because the second portion is that how do you relate the cachexia to roflumilast? And so remember, roflumilast is associated with several kilogram weight loss. And so one of the recommendations made with roflumilast is if you're really, really skinny, you should rethink whether you're going to use roflumilast, and you should be monitoring that patient's weight more closely over time. And then the last question in the last 25 seconds is the role of ICS de-escalation. And so I've shown you what the gold statement and suggests regarding de-escalation, and that it should be considered. Exactly when to consider it, to me, remains unclear. Milan published a very well-cited paper from Spiromics showing tremendous variability year to year in exacerbations in patients. My sense is that if I have a patient who is at high risk, osteopenic, skinny woman, or a man who I think is at risk for pneumonia, I will clearly consider de-escalation in those settings. And that is where I've started using eosinophils, in that setting. What do you think, Milan? I'll let you have the last word.
I think it can be. Incredibly challenging trying to sort some of these issues out, and obviously talking to our individual patients, really bringing them into the conversation about the pros and cons, I think, of each. But I think the good news with roflumilast, at least in particular, is that the chronic bronchitis patients tend to be a little bit heavier,
A little chunkier.
and so it's not always an issue, but certainly can be.
All right. we are a minute over time. So go out and enjoy the rest of the meeting, and thanks for coming so early.
This activity has been jointly provided by Penn State College of Medicine and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/YAX860. This educational activity is supported by an educational grant from GlaxoSmithKline.